So this is the patient. This is a 70-year-old woman who had low back pain radiating to the right hip, walking distance below 50 meters. He was on fentanyl for months. She did everything and did not, which did not work. She had an ectopic pregnancy. She went from another country and had a fan steel incision and also had an appendectomy, so she had like abdominal surgeries there. And she had osteoporosis that was treated with Forsteo for months. In our program of optimization before surgery. She had an anterior physical examination, as you can see, anterior trunk imbalance and full strength in both lower extremity, good pulses and the full range of motion, no radicular tension, and yes, she had a big scar related to that ectopic gynecology surgery. So these are the parameters, the way we measure them, and this is a patient which is coronally balanced, even if she has a 41-degree scoliosis, but requires a 43-degree correction at the lumbar spine. So some concepts here. This is a summary. What we can do with surgery, we can stabilize, we can also decompress, and we can correct deformities. These are the only three things we can do. And when we correct, we want the patients to be in the center of economy. We want to remove all potential compensatory mechanisms. And each one of us may have different alignment goals, and these are my alignment goals. I try to have the patient as close to zero in gap and try to reconstruct as much as possible the Russoli type, and this is very much linked to the location of the apex of the lumbar lordosis. So first thing is checking for rigidity. This is clear, and I'll show you what I did. Coronal plane, we don't look for full segmental correction, we look for balance. She's already balanced. But sagittally, here we need, I think, full reconstruction and full realignment at segmental level. And these are the mobilization strategies we have. And as presented by Munish before, I think it's nice to go stepwise. And you can start from just removing the ligamentum flavum and the interspinous process up to the VCRs. And here you have also another option, which is adding anterior release, as was shown by Munish. So this is my case, and my question here is, this is providing you an idea of flexibility. You have here, we wanted to go up to 65 degrees of lordosis, and by being supine on the CT scan, she's already at 42. She has a fusion at 3, so I don't know. I think you have multiple options here. Who would do that posteriorly, which I think is a good option as well? Who would do this case only posterior? Which I think is a good option. I mean, it's and who would do that anterior and posterior? Okay. So this is what I did, and obviously this is the reason why the case is here. Anterior approaches provide more release, and this was shown by Munish. But I think that now with the devices we have, you can also get direct deformity correction at segmental level, and I think this is good. It also increases the fusion area, so you can remove more cartilage, you can put bone graft, so this is good. And it's restoring anterior column support. So I think that having these vacuums in the front, the risk of having a failure of the construct is high. This is the MRI, and when we have the MRI, we look very much into already there's no big canal encroachment, some lateral encroachment, but we look very much for the vascular windows, especially at L5S1. I think it's a good, nice vascular window, And then I like to go olive, so I go a little bit anterior and L4, L5 to avoid root problems. This is what we do. Many years ago with Carlos Villanueva, who's sitting here in front of me, we look for these patients and see the anatomy. This was done in 2000, and approximately, this is good information, 25% of the population, general population, will not have an adequate vascular window at L5S1. And we normally do the surgeries, I would say 90% without vascular surgeons, but in some cases you need assistance. This is how we plan the surgery, and this is basically the detail of what I normally plan. So I have here what I already have regarding flexibility, and the disc below is 14 degrees, so I can add 5 degrees, and I decide the size of the cages, and with that I get plus 23 approximately, and this is putting me to 64. I think it's good having a straight L2, L3 here, which is fused. She's coronally balanced, so I don't touch into that spontaneous fusion, and I would keep straight. This is going to lower the apex of the lumbar lordosis, and this is going to penalize me in terms of gap score, as you will see, because I'll concentrate all the correction below. This is the kind of approaches we normally do. This is, if you want to do 3D spaces, and the distance is like 95 millimeters, we normally need like a few more centimeters in terms of scar, but you get this nice control of the anterior aspect of L5S1, and you also can have lateral control of the cages. I think most of us would do that. Then we just put the cages, and I think it's extremely relevant to close the wounds perfectly. If you want more information regarding this approach, Sean Molloy did an excellent paper on that. When we do posterior, we add some more correction, and this was commented yesterday, so it's important to have the cages allowing for some motion when you do the posterior release. And I think that's the way you can contour rods and measure them. If you don't have pre-bended rods, it works, I can tell you. And then we check for sagittal alignment at the lumbosacral area. This is layman's hand controlling for that, I think. And we also check for coronal balance, which I think makes sense. Oh, this is not going. When you fuse down to the pelvis, I think it's relevant as well to avoid, when you do a pan-lumbar fusion, to avoid losing coronal balance, and this is one of the methods that can be used. And this is the result we got. As you see, the cages are in the lower part, so this is increasing very much the lumbar distribution index, so you have a penalty in the gap score, which is +3, and then the rest is straight, and in fact, we got where we wanted to go. And this is the calculation, and this is how you see how you got the correction. And I insist, it's important to have more motion below. Don't put screws in two vertebrae to get motion, and you can close and readjust your alignment here, and this is the way we do it. Point, which I think is relevant if you go for A-leaf, and you go a little bit oblique, you need to take care of the contralateral root. I think this is important, and in this, and I would advise you to monitor that and monitor the contralateral root as well. And sometimes you have to stop and put shorter cages, as in this case. And potential contraindication for that surgery, radiotherapy is probably one of them. Adhesions, so look for abdominal and vascular anatomy. But vascular anatomy, even if it's no window, as in this case, you have a lateral window. Even if it's 5-1, you can get there and put the cage and do like an olive at 5-1. This works as well, and you can use it. And that's it. That's the case. So comments if you have questions. Thank you.